A very good afternoon. I'm talking on the sinonasal malignancy involving the anterior skull base. So as we know, the skull base is a very critical structure because of the neurovascular proximity. And when the tumor involving the sinonasal cavity and reaching to the skull base, the management is more challenging. So I will be speak on the general principle, what are the surgical approaches like endoscopic and open, what is the management of orbit if the tumor is going into the orbit, neck management, chemotherapy, role of radiotherapy, role of a particulate radiation, and the take-home message. So the sinonasal tumors are rare. It's 3 to 5% of the head and neck tumors, and there are different subtypes are there. And most commonly are the squamous cell carcinoma, followed by the intestinal adenocarcinoma, undifferentiated carcinoma, and neuroendocrine tumors. There is no randomized controlled trial that defines the optical treatment. That is because of the rarity, heterogeneity of the tumor, and whatever data is available, either institutional data or observation study. So, however, the stage at the presentation is generally the highly predictive of survival, and despite a maximal treatment of the primary tumor, local, regional, or distal metastasis recurrence can occur even after the many years. Surgery is a mainstay of a treatment followed by the radiotherapy. At present, the surgical strategy has to be driven by the cancer histology and this extension rather than the available surgical expertise. In diagnostic workup, we have to do a nasal endoscopy, CT, and MRI to know the exact extent, site of origin, and the nasal endoscopy guided biopsy is prime importance. And histopathology, if it is a rarity tumor, second histological opinion, it should be done. For planning of surgery, even there is a role of a PET CT scan to see the distant extensions of the tumor. It is a multidisciplinary protocol, like in stage 1, stage 2, stage 3, and stage 4. In resectable disease, the surgery has a role. If the brain parenchyma, cavernous sinus, carotid involvement, and bilateral orbital involvement, these are the unresectable tumor, and that should be treated with the palliative intent. In the surgical management, it is a mainstay of treatment, and the goal should be like it's a wide margins can't be taken like in the other malignancy like a squamous cell carcinoma, laryngectomy. These are the 1 to 2 millimeter negative margins can be taken in the case of a tumor involving the skull base. So the complete resection of the all visible tumor while preserving the function and cosmesis, and this is like a either it is a open or an endoscopic approach. The oncological and survival outcome of the both approaches are similar, and the careful selection of the approaches is to be done before doing this, before planning the surgery. And that the surgical team is like head and neck surgeons, neurosurgeon, microvascular surgeon for the reconstructive. The surgical approach is like endoscopic, open, or a mixed approach if the condition demands. Like in this paper, this indications when the tumor is in the confines of the nasal cavity and paranasal sinuses, these are there are the indication for the endoscopic endonasal resection. If the limited periorbital invasion is there, so we can resect the limited periorbital endoscopically. And if there is wide periorbital invasion is there, we can go for an organ preservation protocol and then save the orbit. So in the endoscopic surgery, the principle like hypotensive anesthesia, septal flap if it is not involved, there is centripetal pattern of resection. So this is a debulking of a tumor. So once the origin identified, the centripetal mobilization of tumor is done. If the cribriform plates are involved, then draft 3 frontal sinusotomy and exposure of a skull base from posterior wall of frontal sinus to the plenum is need to be done. And if the dura is invaded, resection and the dural repair is always in 3 layers. So the principle are same even in the case of open approach or open craniofacial resections. Pre-operative requirement, we should the thorough counseling of the patient and to explain about what is the nature of a tumor, what is the extent of surgery, and what can be the potential complication after the surgery, and we have to give the broad spectrum antibiotic. So in the case 1, like we can see this tumor involving the sinus, this maxillary sinus, ethmoids, and we can see there is limited periorbital invasion. It's going into the left orbit, but it's not infiltrating into the proper orbit as we say. So the key area for management of this case, so primary, we have to deal with the skull base, deal with the orbit, and what is done with the neck. So the orbit can involve in the preform pathways or extension or a neural spread can be there. So we did a resection of a composite resection and reconstruction with the submental flap, and is for the squamous cell carcinoma, the patient posted for the post-operative chemoradiotherapy. In the case of adenocarcinoma, it is the most commonly mucosal epithelial malignancy, predominantly in the male because of the exposure, and the bilateral ethmoidectomy is indicated because some this like inhalation is the most common route, so it can have the non-involved site can even harbor the tumor in the cases. So in this is case 2, this again same the same endoscopy resection. So given possibility of tumor spread to leptomeninges, there is a role of a brain irradiation can be there. In a case of olfactory neuroblastoma, the surgery should exclude the olfactory bulb in the case of unilateral. If the bilateral, both olfactory bulb needs to be resected. So in like Kadish A to B, A, B, C, D, the prognosis is decreased, right? Go from A to C, A to D, and there is a more histological characters like Himes classification is there. So nuclear pleomorphism, fibrin actis, rosette, and necrosis is depend upon that. So like case 3, this is olfactory neuroblastoma. We did induction chemotherapy. Now this tumor is reduced, so we can remove it very easily. In case of adenocystic carcinoma, so in this perineal invasion is there. So it can lead to the significant skull base damage. It can go to intracranial extension. But like this ACC is recur most, but the overall survival is better than the other malignancies per se. So in a case of recurrence, we need to do the PET CT. Again, this is the ACC. We read complete resection of a tumor. So there is a role of a positive post-operative radiation therapy, like either with the IMRT or proton beam therapy because of close proximity to the brain. So the proton beam therapy is very expensive, but it is helpful in such case. Like in the soft tissue sarcoma, as we know, this is very extensive tumors and mostly involving the pediatric age group, like you can see in this picture. So like we start induction chemotherapy, and after 3 induction chemotherapy, these patients like this, and we can then whatever the residual tumor, then we can resect it. Same in this picture. This is a dual malignancy, like myoepithelial carcinoma, so 2 component, myoepithelial cells and the epithelial cells. Again, the endoscopic resection. So in the post-operative care, all the patient undergoing the skull base reconstruction require the brain CT scan and the post-operative period to see whether it is completely tumor removed or not, or to see the extent of the pneumoencephalus. Nasal packing, this all we know. So in compared to the open cranial resection, the morbidity and mortality is more in the case of open rather than the endoscopic. So what is the management of neck? The nodal metastasis is around 10%, and if it is involved, so in the T3 or T4 N0, it need to be resected, and T1 and T2 in case of a free flap need to be done. So the take home message is the neck management, the therapeutic neck dissection, either in PO or post-operative therapy or concurrent chemoradiotherapy. Orbit management is necessary, like peri-orbit are not involved, then preserve the orbit. Orbital preservation can be done in a multimodalities management. Orbital floor reconstruction need to be done for a functional eye, and appropriate reconstruction of defect like pedicle, free flap or prosthesis if the orbit extension is there. Adjuvant role in the case of advanced malignancy. A role of particulate like proton beam therapy if the tumor is deep seated and the several organ at the risk in the like paranasal sinuses with a particular suitable. So it can matter of the fact, you can see the biology is the king and the selection of the cases is the queen. The technical details and the surgical expertise are the prince and the princess. So they try to overthrow the power of the king and queen, but at the later they can get some benefit, but at the end like tu bacha hai, tera baap to mai idhar ho karke. So the ultimate is the tumor biology. So whatever the management is to be histology oriented. So pathology have a most immense role in a case of I think like in evolving role in the head and neck malignancies. Thank you.
Thank you, sir. Thank you. Sir, I request our chairpersons to please felicitate Dr. Mahendra Katre, sir. I request chairpersons to give certificate to Dr. Shyam Somani sir. I would like to call Dr. Shilpa Jetliya ma'am for her talk.